Welcome to the module on basic lung ultrasound and interstitial syndromes. This is module number 1 for lung. Pleural effusions and consolidations will be covered in module number 2 of lung. I'm Dr. Gordon Johnson. So just to start with the learning objectives, we're going to try to identify the probes that you want to use when you're doing lung ultrasound. Also identify the probe positioning and proper technique at scanning for the lungs. Then we're going to talk about identifying the pleural line and lung sliding, identifying A lines, identifying B lines that are consistent with interstitial syndromes, and then just a quick intro into subpleural consolidations and effusions. That, again, will mostly be covered in module number 2. So the first question is, why do we ultrasound the lungs? POCUS is unique, and it does ultrasound the lung. There's no referral at this point for lung ultrasound, but it's something that can really answer clinical questions immediately at the bedside, like all POCUS features. The nice thing, though, is it's more sensitive than a radiograph for finding fluid, which is usually what we're looking for. It does not involve any radiation, often no cost to the patient, no risk. It's really better at identifying septations in complicated fusions compared to CT. And then it complements your physical exam, or often confirms suspicions you had from your physical exam for the patient, and can avoid further imaging at times. It's also easily repeated, can be done as needed, can be done daily, even multiple times a day, to follow a patient's clinical condition. It does not require a technician, like all POCUS features. The disadvantages is it does take extra time. You're going to have to spend time with the patient. It's much easier to click a box in Epic at times and order a chest x-ray or a CT. And you can miss pathology, and especially in inexperienced hands. You want to really be careful with this. Air does disperse the ultrasound waves, so you can miss things that are deep to aerated lung. So next we're going to talk about probe selection and proper patient positioning. And in honesty, all 3 of the probes do work, but I think generally speaking, people are going to prefer that the linear probe be used for lung sliding and to look at the pleura closely. And sometimes the lung setting itself is better to do this and look at A lines. To looking deeper with consolidations and effusions, you're generally going to use the phased array or cardiac probe, or the curvilinear or abdominal probe. And oftentimes you put it on the abdominal setting, but I always encourage people when they're learning POCUS to try the different settings between abdomen, lung. I've even used cardiac settings sometimes to look at pleural effusions. So again, here's the 3 probes that we're going to be using. And just to review, when looking at the pleural line, I suggest the linear probe, particularly to look at lung sliding, and the other 2 probes to look for consolidation, edema, or effusions. So looking for lung slide, initially you can see here we're fanning the probe back and forth. You want to be exactly perpendicular with the pleural line to be able to see it brightly and to get other things out like A lines later. And you'll notice that the pleural line kind of dives deep and then comes more towards the surface when you're truly perpendicular with it. Here it's deep, now it's coming to the surface. We're truly perpendicular, and below that you can see an A line down here come out. You can also see closely that the lung sliding is there, often described as ants crawling on a log. You see the parietal pleura here effaced with the visceral pleura, and the visceral pleura is sliding back and forth. Here's another example of lung sliding. Again, you want to set your depth and gain here so that you're not very deep, and looking very close at that pleural line, you can see it sliding back and forth. So this rules out the presence of a pneumothorax. But it's very important to remember that the absence of lung sliding here does not mean there is a pneumothorax. You can have blebs or pleurodesis, scars, an occluded airway, apnea, other things that cause lack of pleural sliding. But again, if you see lung sliding there, you know that in that region there is not a pneumothorax. Also, you might run into something called lung pulse, where you see the lung pulse back and forth with the heartbeats. This also rules out pneumothorax, especially if the person isn't breathing, but their heart is beating. You can see the pleural line kind of bounce back and forth with lung pulse. And I always recommend you check lung sliding before you do a procedure, such as a subclavian line or a thoracentesis, and then repeat it again after doing the procedure to make sure the lung slide is present. Why do it before? You want to make sure you see good lung slide before you do the procedure, so you don't get nervous that you caused a pneumothorax when it turns out they had a chronic finding like a bleb or a scar up there. You'll hear a lot about the M mode to look at lung sliding. And here's an example. You put in N mode, you're looking at the lung slide here, and you see the sandy beach sign here. Here's supposedly the ocean and the sandy beach. We use this to take a image and make it 2D if you want to just screenshot that for the chart to show that there is a presence of lung sliding. If lung sliding isn't present, you get what they call the barcode sign, where there's no lung sliding seen here. And with your M mode dropped right down through the lung, you'll see just this barcode appearance. So again, just to obtain a 2D image before and after your procedure, this proves that you didn't create a pneumothorax. If you're truly up in the apex of the lung where a pneumothorax would be. There's another term you might run into called lung point, and this is an example of it. It's where you see the lung slide through partial part of the view here, but no lung sliding over here. So this is very specific, but not sensitive for pneumothorax. And the mechanism basically is you're seeing here there's a pneumothorax, and then as the lung comes up, you see the lung come up into view as it does here. So this is lung, and off to the right is pneumothorax. So the other thing that we had mentioned was A-lines. As we said before, these are reverberation artifacts. You're seeing the pleural line and pleural slide here, and then exactly twice the distance here, you see the A-lines here and here. And the mechanism here is just a reverberation as we send sound down through the skin and down into the pleural line. It bounces back and the machine creates a line there. But oftentimes you're getting the sound coming down, bouncing up, bouncing off the surface of the skin and the probe, bouncing back down and back up. So that makes the machine think there's another line here, and the same is true if there's 3 bounces, and so on. So this indicates that there's air, okay, underneath this. It does not indicate that there's normal lung necessarily. You can have asthma, you can have an occluded airway, but the interstitium here is filled with air is what that's telling you. So there's no, in this area, there's no consolidated pneumonia, there's no interstitial syndrome such as pulmonary edema. Now here's an example of B lines that usually efface the A lines when there is an interstitial syndrome. This is an example of a ringdown or comet tail artifact where you're seeing these lines shoot down. They're often described as being a kind of a flashlight on a foggy night. Okay, again, they're effacing the A lines. To be significant, you want to see 3 or more of these between each rib space. So here's a rib, and we're seeing more than 3 in this area. You can see this normally down at the dependent portions of the lung, so down at the bottom of the lung, you can see especially 1 or 2, or if someone's been lying in bed. But you shouldn't see this through other portions of the lung, and you generally shouldn't see more than 3, especially between multiple rib spaces. So again, extending down to the bottom of the screen and described as flashlights on a foggy night. Here's an example at a concert of something that looks like B lines coming down. Again, just to review, so you normally can see these down at the dependent bases of the lung, and they don't always indicate that there's pulmonary edema. But when you do have pulmonary edema, especially cardiogenic pulmonary edema, you'll often see with this a nice smooth pleural line there, okay? And the number of B lines do correlate with the amount of edema. So when patients have more pulmonary edema, you generally get more B lines and more diffuse. But remember, you can see these in other entities, such as pneumonia, which is usually focal, ARDS, pneumonitis, interstitial lung disease, pulmonary hemorrhage, other things. And here's a schematic of the different syndromes we see with the lung. So here you're seeing the thickening of the interlobular spaces and around the alveoli. And the thought is that sound comes down here and bounces around and then just comes up periodically. So it creates these long lines coming down called B lines. Now later we'll talk about consolidation when all the alveoli are filled with fluid and you get a much different picture here. You're seeing what we call hepatization of the lung. Okay, with pleural effusion between the lung and the parietal pleura, you see generally a black stripe in there, which indicates fluid. So a lot of the protocols that talk about lung ultrasound use lung zones. Here's an example in the blue protocol. The different lung zones on each side, 1, 2, 3, and 4. Here it is on one of the GE machines where you can actually plug in to the machine to indicate where you're scanning, and you can see where the person is finding B lines. So here's an example of multiple different areas with B lines. Here's 3 here, here's 3 here, multiple spaces. I'd want to look around more than this, but this may be consistent with congestive heart failure if it clinically fits. So again, the different points that you can look on the chest are these different. And then the one that's often left out, but I find really helpful, is actually to sit the patient up, especially when you're auscultating, after you auscultate, and look at the posterior portions of the lung. This is often where fluid ends up accumulating, and you can also see if that fluid is large enough to do a thoracentesis. So if the patient's just lying in bed, a good way to look down at the base of the lung is just to have their arms up again like they're lying on a beach. Keep your knuckles to the bed in the most dependent portion because this is where the fluid is going to go. But again, you can sit them up here, like this example, and scan throughout the lung, up and down. You find the liver down here and then come up from that. You'll also see examples of subpleural consolidation. This is an example of a pneumonia. So here's the pleural line here that's real jagged, and then you got this small subpleural consolidation over here. It's consistent with a pneumonia or just a focal pneumonia, but not completely consolidated. There you can see the pleural line there. It's just below the pleura. So of course, in this day and age, we have to talk about COVID, and it has very specific findings I find very helpful, again, if the clinical history fits. So here's an example just sliding up and down the patient's anterior chest. You'll see here B lines, normal lung with A lines, B lines up here, sliding down A lines, sliding down further again, subpleural consolidation. Down at the bottom again, when we go down, right here, you'll see a very jagged pleural line there, right there. So with this kind of a picture, it's very typical of COVID. Here's the CT I'm sure you've seen with COVID, with all these spotty, diffuse, scattered ground glass appearance. And again, that's the place where you might see normal lung A lines up here, but as you scan down here and here, you'll see some subpleural consolidation, a jagged pleural line, and B lines shooting in this kind of disorganized fashion. Unlike pulmonary edema that would be diffuse with B lines, this is more patchy. And then finally, just looking at lung curtain here, this is something, again, with your knuckles down to the bed, have the patient breathe in and out, and you'll see the lung come down clearly. So if you're down at the most dependent portion of the lung, you're not going to see any, you would see fluid if it was there. So this person does not have a pleural effusion. And again, we'll talk more about that in the next module. That's the end. Thank you.